cause of cardiogenic shock is an acute myocardial infarction. When we get into cardiology, we'll talk more about this in detail, but one of the things that heart muscle cannot do when it dies is that it cannot contract. So, if you have a large portion of the left ventricle in particular that dies off, as a result of that, the heart as a pump, and we call it a forward pump, of pushing blood forward into the body, now begins to become affected. And this is the whole crux, this is the whole basis for cardiogenic shock. When we've got a patient that has some type of ischemic heart disease, so for example, they have long-term problems with heart attacks, generally what they're looking at is loss of about 40% of the left ventricle. I'll never ask you that percentage, but just understand, Yusef, that it is the left ventricle, when we get that certain amount, that it begins to fail as a pump, and now shock begins to come onto play here. Again, the most common cause is going to be patients who have heart attacks or myocardial infarctions that lead to this ineffective pumping of the heart. When we get into cardiology, we'll talk more about this because you have both a left pump and you have a right pump. The right pump's the right side of the heart, the right atria, the right ventricle. As a result of that, what happens is for the right side of the heart sends the blood to the lungs and then back to the heart. Left side of the heart is the left atria, the left ventricle. That sends the blood out through the entire body and back to the heart. Specifically, one side of the heart can fail before the other. Usually it's the left heart that fails first and then the right heart. We get into cardiology, we'll talk about those specific things, but that's the thing that I want you to remember is that there's two pumps within the cardiac system and they serve two different purposes. Now keep in mind that the damage that the heart sustains could be from one massive heart attack or it could be a bunch of little heart attacks over a long period of time. So with cardiogenic shock, basically what happens is patients now begin to have shortness of breath, they fatigue easy, they're not able to move around really well. And that's as far as I want to go into cardiogenic shock because like I said, we'll talk more about that in cardiology. So again, the basis for cardiogenic shock is failure of the heart as a pump, all right? Next type of shock is called obstructive shock. Now, Nico, when I say the phrase obstructive shock, what does that make you think of? Yeah, so we've got something that is blocking. So in obstructive shock, shock occurs when there is something that is blocking blood flow either in the heart or within the large vessels of the body, okay? In a condition known as pericardial tamponade, okay? Remember, the heart is surrounded by a tough fibrous sac that's called the pericardium. If we begin to get fluid under the pericardium and above the heart muscle itself, whether that's fluid from disease or whether that's fluid from bleeding, if it's not corrected, that fluid will begin to enlarge and it'll begin to compress on the heart. And as a result of that, it'll begin to obstruct the pumping action of the heart, okay, leading our patient into obstructive shock. We can have obstruction of blood vessels. When we begin to talk about OB emergencies, we'll talk about why it is so very important that if you've got a lady who is in late pregnancy, in her last trimester, you don't lay her flat. Why? Because she's got this fetus, and directly behind the fetus is the inferior vena cava. So if you lay her flat, and that fetus now presses down on the inferior vena cava, that's going to obstruct blood flow coming back to the heart, putting her into shock. and it causes a huge problem. We can have a pulmonary embolus. Remember, the blood goes from the heart through what to the lungs? Pulmonary artery or pulmonary vein? Pulmonary artery. If we get an obstruction either in the pulmonary artery or in the pulmonary vein, now that blood is obstructed and it can't get there. The end result is our patient goes into obstructive shock. As a result of that, the same signs and symptoms begin to occur. With some conditions of obstructive shock, the patient goes into cardiac arrest. So, for example, a pulmonary emboli. Many times the first sign or symptom you'll have with a person who has a pulmonary emboli is they're sitting there, they're feeling fine, they look great. The next minute they're in cardiac arrest. Why? Because the blood flow between the heart and the lungs, or between the lungs and the heart, has been obstructed. It's been blocked off. All right? Quickly, we're going to go through anaphylaxis because we've talked quite a bit about this. But basically what happens in anaphylaxis is you get chemicals. In particular, you get a chemical that's called histamine. We're all familiar with histamine because no matter where you live, we have flowers that bloom in the spring, okay? And as a result of the pollen in the air, it comes in and it triggers a histamine release, which causes our noses to swell up, which causes our eyes to water, causes us to sneeze, to cough, causes maybe some swelling in our face, okay? That's the exact same thing that you're going to see with an anaphylactic reaction. The problem with histamine in anaphylaxis is the fact that it's a huge amount, much more than what we would normally see within an allergic reaction like hay fever for the summer. And this leads to, again, dilation, massive dilation of the vessels, and permeability of those vessels. So not only do we have enlargement of the vessels with the same amount of fluid that drops the pressure, the plasma begins to leak out through tiny little holes that develop within there. This can happen. This is the scary part about anaphylactic reactions, okay? The most common things that we have anaphylactic reactions to are like insect stings, eating shellfish, and peanuts, okay? The scary thing about anaphylaxis is that you may never have ever been allergic to insect stings your entire life. You may have eaten peanut butter cookies and peanut butter your whole life. You may have enjoyed shrimp your whole life. And you are exposed to those, say, sometimes in your 40s, and you can have an anaphylactic reaction, okay? One of the things to keep in mind, and we'll have a section on anaphylaxis, but one of the things to keep in mind with anaphylaxis is the faster the onset of the symptoms, the more serious the anaphylactic shock is going to be. So if the symptoms occur over hours, generally it's going to be mild. If it occurs over just a very few minutes, you may have to resuscitate your patient, all right? With these patients, every other exposure after that increases the risk for a reaction. This is why, and it's been 2 years since I've been on a plane. Used to fly basically about once a month to meetings and conferences and stuff. But periodically they would announce, we're not serving peanuts today because we have somebody on the plane that has an allergy to peanuts, and I'm okay with that. But basically, if they get exposed to that, every subsequent reaction is going to be worse, and it tends to produce a more severe reaction. Generally, what we're looking at here, again, is that histamine release that comes in and causes a problem. The other thing that occurs with anaphylaxis is that while it is, it keeps wanting to update my computer. While it is causing vasodilation, it has the exact opposite effect on the bronchioles, is it causes them to clamp down. So as the bronchioles now begin to clamp down, as a result of that, we have decreased amount of air that is able to get into the lungs. So we have a pressure problem And we have a hypoxia problem that's going on with anaphylaxis as far as when we're doing this. Most of the time, anaphylaxis is going to be accompanied by hives. We all know what hives look like. Make sure you know the medical term for hives is urticaria, URTICARIA, urticaria. So the patient will be itching, and again, how quickly that onset occurs is determined as far as what comes on and begins to play. Not only do we have a problem with some of the fluid leaking out of the vasculature as far as causing a drop in the blood pressure USF, but if it leaks out up here in the upper airway, it can cause an airway issue as well. So anaphylaxis, bad stuff. Basically what we want to do is we want to get this patient epinephrine as soon as we possibly can. Scope of practice in Kentucky says that you as an EMT, you can draw up epinephrine and give it via syringe if the patient doesn't have their own EpiPen, okay? So one more that we're going to talk about, and this is the one that you were asking about, was septic shock. We'll go through this pretty quick, is basically we're looking at, again, we have an assault on the body from some bacteria, some viruses that overwhelm the body and put them into shock. As a result of that, the body's mechanisms are usually pretty good at keeping it at bay, but depending upon the situation, now they begin to shift. Again, we see dilation and vascular permeability. Fluid begins to leak out of the vascular as well. As a result of this, we don't get perfusion to the organs. And if we don't get perfusion to the organs, eventually cells begin to die in those organs. And if we have enough cells that die off, then the organ itself begins to die off. And in particular, we're concerned about the brain, the heart, and the kidneys. We're concerned about all of our organs, but those are the three that can be left with the biggest problem. This sepsis is really good about leading to a condition that's known as multi-organ failure. It just simply, because of the infection is everywhere, it affects a lot of different organs, okay? Septic shock's really complex, but the big thing that you need to know about it is that fluid leaks out and we have vascular dilation that comes into play. Much like we saw with anaphylaxis, the fluid can leak out and go into the lungs. Septic shock does not cause bronchoconstriction, so we don't have that problem to worry about. But what we do have to worry about is the fluid that collects within the alveoli. You've heard me say time and time again that fluid and gas cannot occupy the same place at the same time. So Nico, when we've got fluid in the alveoli, guess what we don't have? We don't have gas exchanges taking place and going on in there. The last one that we talked about, and we kind of touched on this, is neurogenic shock. Understand that that's a disruption between the brain and the body and the vasculature. So what I'm going to do is I'm going to stop there and see if there are any questions, because I've got 10:25, or 10:24, it's coming up to 10:25. I want to make sure that you have your 15 minutes to look at your exam. Any questions on what we've covered? There's a little more in your text that I will not have covered as far as shock. The big thing I want you to keep in mind with your patients is that don't be afraid to give shock patients oxygen. And the other thing is keep your patients nice and toasty warm, okay? Nice and toasty warm. And we'll talk more about that particularly as we get into trauma. Any questions? All right, so let me stop my recording here.